Onc Live Insights is a video editorial program produced by Onc Live.
Use of Feradak is going to evolve very rapidly in the relapsed refractory space. We've seen the Panorama 1 data where it was used in 1 to 3 lines of therapy, and we see an improvement in progression-free survival from 8 to 12 months. And we've seen all that data. However, it's important to realize and understand that the FDA approval, at least in the US, is actually in patients who've had prior lenalidomide, bortezomib, and more than 2 lines of prior therapy, so in that 3rd line space specifically. That's an area where we don't see data with Aspire, and that's data that the Eloquent data does not apply to. So I think that's actually very important in that 3rd line setting to consider the use of combination of Velcade and panobinostat in that specific FDA indication. And when you actually look a little bit more closely in that space, in fact, the improvement in progression-free survival is from approximately 4 months to 12 months, so approximately 8-month improvement in progression-free survival in that indication of patients who've had prior lenalidomide and prior bortezomib and 2 lines of therapy, which is many of our patients now. And in fact, as you look at the hazard ratio of 0.5, that's actually better than what we see with the Eloquent and the Aspire data. So I think there's a really significant benefit to this combination in that setting.
Pomalidomide is the 2nd generation immunomodulatory drug approved in Europe in combination with low-dose dexamethasone for the treatment of relapsed and refractory myeloma patients who have previously exposed to bortezomib and lenalidomide, and patients had to be refractory to the last line of therapy. Pomalidomide is an oral drug given at a dose of 4 milligrams on days 1 to 21, followed by a week rest period. And ideally, the treatment is continuous treatment until progression disease.
We'll typically integrate pomalidomide into the relapsed refractory setting after a patient's already been exposed or relapsed or refractory to prior lenalidomide-based therapy. I think there are a couple of patients that really benefit from pomalidomide-based therapy, and those are those patients who had a long progression-free survival or benefit from prior lenalidomide-based therapy. So those patients who are quote-unquote IMiD sensitive, I think really benefit from additional pomalidomide-based therapy and may get the best benefit. Oftentimes in that setting, patients with high-risk disease or certain subsets of high-risk disease may also benefit from pomalidomide-based therapy, and that's based on Xavier Lulu's data from ASH 2013. There's also some very nice combination data with pomalidomide plus cyclophosphamide, and so that's a nice combination as well. And we recently published just this past month on the combination of pomalidomide and carfilzomib. I think that's also a very active combination as well, with very high response rates in that relapsed refractory setting. So I think those are a couple of nice combinations to be used in that setting for patients who are relapsed or refractory to lenalidomide-based therapy. In particular, those patients with high-risk disease, I think, have a really benefit from a combination of carfilzomib and pomalidomide in that setting as well.
Carfilzomib is the 2nd generation proteasome inhibitor, and also it was introduced in the clinic in order to try to overcome the refractoriness to bortezomib and even thalidomide or lenalidomide. Carfilzomib single agent was first approved in the US at a dose of 27 milligrams per square meter for the treatment of patients with myeloma relapsed and refractory after bortezomib and lenalidomide. And the rationale was a pilot trial, a phase 2 trial in which approximately 200 patients were included. Most of them were double refractory to bortezomib and lenalidomide. And again, approximately 1/3 of the patients responded to this combination. And when we focused on the patients double refractory to bortezomib and lenalidomide, the overall response rate was around 15%. Again, with a median duration of response of approximately 8 months, median PFS of 4 months, but most importantly, these patients were able to prolong the overall survival in approximately 1 year. This was the rationale for the approval of carfilzomib in the US. What was the problem in Europe? In Europe, the problem was that carfilzomib single agent was compared with the best supportive care for patients double refractory, cyclophosphamide plus prednisone plus corticosteroid. And we know that cyclo plus prednisone is an effective combination in double refractory myeloma patients, and this was previously shown some years ago by Saji Kumar in a trial reporting the outcome of double refractory myeloma patients. And this was the reason why carfilzomib was not superior to cyclophosphamide plus dexamethasone or plus corticosteroids. And this was the reason why carfilzomib single agent has never been approved in Europe for the treatment of relapsed and refractory myeloma patients. However, of course, carfilzomib is an effective treatment for relapsed and refractory myeloma patients, and we have now results coming from phase 3 randomized trials, KRD, compared with lenalidomide and dexamethasone, and carfilzomib, lenalidomide, and dexamethasone has demonstrated to be significantly superior in comparison with lenalidomide and dexamethasone, and the same in other phase 3 randomized trial in which carfilzomib plus dexamethasone has been compared head-to-head with bortezomib plus dexamethasone. How are we going to integrate carfilzomib in our clinical activity? Here in Europe, I think that in Europe and also probably in the US, carfilzomib will be moved to early stage of the disease. And from my point of view, now carfilzomib will compete with other combination in the first relapse, because most patients are going to receive bortezomib probably and lenalidomide even in the upfront setting. So the first option after first relapse would be carfilzomib-based combination, just carfilzomib plus dexamethasone or carfilzomib plus lenalidomide and dexamethasone.
Evidence for the use of panobinostat suggests that it may have quite a different range of clinical efficacies to other agents from other classes. And this is not surprising because it is a very different drug to the ones that we've been routinely using. The trials that have been undertaken suggest that it synergizes very efficiently with both proteasome inhibitors and immunomodulatory agents. The trials which have driven its approval for use, however, have been based on combinations with proteasome inhibitors. In my practice, I would be inclined to use it relatively late in the disease course based on the available evidence. The reason for that is that from the pivotal Panorama 1 trial, the subgroup which certainly derived the most benefit, and in fact a doubling of progression-free survival, were those patients who'd had 2 prior lines of therapy or more, including both a proteasome inhibitor and an IMiD. So based on our standard where we cycle through therapies, it's probably at that third line presently where I'd want to introduce panobinostat, probably with a proteasome inhibitor to try and recapture disease control and really get as much mileage out of the reintroduction of that proteasome inhibitor as possible. The issues that we face relate to tolerability, and I think I would be inclined to use proteasome inhibitors such as bortezomib in the most tolerable fashion in combination with panobinostat, so a subcutaneous weekly approach. I'd also be inclined in my own practice to use the panobinostat on a week-on, week-off schedule, as we've had fairly extensive experience in using this agent, and we found that that is the most tolerable schedule.